Hi, everyone. I'm Sarah Caslow. I'm a Chief General Surgery resident at NYU, and my colleague.
Hi, I'm Pradeep. Is it on? Hi, I'm Pradeep. I'm one of the pancreatologists and advanced endoscopists at Stanford.
So we have the pleasure of moderating this Controversies in Pancreas Tumors, PDAC, and Cysts session. It'll be 15-minute presentations followed by a Q&A at the end of the session. So we'll just go ahead and get started. Dr. Gonda, who's a professor in the Department of Medicine at NYU Grossman School of Medicine and serves as the Chief of Endoscopy and Director of the Pancreatic Disease Program. As a fellow NYUer, he is literally the go-to for anything advanced endoscopy within the institution and a great resource for us at NYU and in the area generally.
Thank you. Thank you, Sarah, for that. And thank you very much for the organizers for inviting me and for, I think, inviting all of us in this session to talk about this still somewhat emerging, but hopefully after these talks, a little bit more something that enters into your mainstream in the management of different pancreatic tumors. So I'm going to focus on neuroendocrine tumors and essentially endoscopic treatment for neuroendocrine tumors. As a very brief outline, I'm going to talk a little bit about risk of progression, especially about risk of progression in localized neuroendocrine tumors, some of the management approaches, how EUS guided therapies fit into potentially the management of neuroendocrine tumors, and then some of the studies that either we have conducted or we have been involved in, and then finish up with sort of my outline of how I incorporate it into practice at this point. I'd like to start with this slide because I think it still sort of surprises me, and it's perhaps not something that is as upfront in our thinking when we think about incidence of and the frequency of this disease. It is really a very fast-growing solid neoplasm, or it's an increasingly recognized solid neoplasm. The majority of newly diagnosed neuroendocrine tumors that are increasing in incidence are relatively small localized disease. But I think for those of you who see a lot of patients with incidental findings, it is a very different type of incidental finding than pancreatic cysts, which we all see. It is very scary to read in an MRI report that there's a 1.5 centimeter pancreatic mass present, and for that reason, I think it's important that that we pay attention to how to better manage this disease. In terms of a very brief overview of sort of how do we stratify pancreatic neuroendocrine tumors in terms of risk of malignancy and progression. They're divided into non-functional and functional tumors. And on the non-functional side, and to some extent also on the functional side, tumor size and cystic versus solid phenotype are strongly correlated with risk of progression, with kind of the size differentiations between less than 2 centimeter lesions being relatively low risk, and we'll dwell into this a little bit more, and above 3 centimeter size lesions generally thought of as high risk of both progression and metastases. On the functional side, without getting too sort of deep into this, I think the important message here is that insulinomas, unlike all the other functional neuroendocrine tumors, carry a very low or a relatively low risk of malignancy, whereas other functional tumors carry a higher risk of malignancy. So just kind of diving into this question of, again, focusing on small neuroendocrine tumors, especially since this is what I think is an increasingly recognized entity, and where I think, as you will see, I think alternatives to perhaps surgical management are important to explore. I think if you sort of substratify, and this is a nice recent publication, substratify the risk of progression of less than 1 centimeter, and then between 1 and 2 centimeter neuroendocrine tumors, it does, and these two curves here, the red and black curve, compare outcomes of patients who are surveyed versus undergo surgery. Under 1 centimeter, there does not seem to be a significant impact of surgical resection, whereas in the 1 to 2 centimeters, we're starting to see a little bit of a differentiation. And again, above 2 centimeters, and in some of the guidelines, perhaps above 3 centimeters, are generally thought of as higher risk lesions. These are some of the studies that have focused, again, specifically on the metastases rates, especially lymph node metastases and such in smaller tumors. And there is a great deal of variability. These are mostly case series or cohort studies. And some studies have found very low rate of lymph node metastases, even in less than 3 centimeter lesions. But some of the more recent ones have found lymph node metastases in greater than 2 centimeter lesions in upwards of 10%. It is important to point out that in addition to size and functional status and the cystic solid component, biopsy-based further classification of neuroendocrine tumors helps with distinguishing low-grade versus higher-grade tumors, initially based on Ki-67, and then actually work really that as so many of our pancreatic biomarker work is spearheaded from here in Pittsburgh by Dr. Singhi's group. Some of the additional molecular markers help further risk stratify neuroendocrine tumors. So when one sees a pancreatic neuroendocrine tumor, the initial evaluation based on this data really is to confirm that there is no extrapancreatic disease. This usually involves a dotatate scan. I think for most of these tumors, an endoscopic biopsy with further classification based on grade is important. And this is the NCCN updated guideline for current recommendations. And I'm going to focus in the middle again. I think the data is reasonably strong, that I think observation is an acceptable and safe approach to very small, less than 1 centimeter lesions, and perhaps above 2 centimeter lesions. Surgical resection is still the current standard. In between, it's really not clear. There are many surgeons in the audience, including my moderator, so I will brush over this slide very quickly because I'm sure that the mortality and morbidity numbers are debatable. But essentially, for these in-between lesions, the options are various surgical resections, essentially Whipple procedural distal pancreatectomy, and in select cases enucleation. I think it's fair to say that all of these procedures have not insignificant morbidity and potentially mortality associated with them. So why do we think about ablation, or where do we think about ablation in this? So I think the rationale for this is that these lesions, the sort of localized pancreatic neuroendocrine tumors, carry a long-term risk. In smaller lesions, this may still be a significant long-term risk of progression. Surgical alternatives have significant morbidity. And I think, again, stratifying based on size of localized neuroendocrine tumors, the sort of quote-unquote sweet spot is the 1 to 2 centimeter lesions, which may carry a not insignificant, a real risk of lymph node metastases and progression. But at this point, majority of these will not be invasive tumors, and perhaps an ablation approach is reasonable. So what are the ablation options? This is a growing list. Most of these are not necessarily currently available here or anywhere in the world, but they quickly break down in chemical ablation, which I will quickly mention as an approach, and perhaps as something that has a role, to non-chemical ablations, which there's a number of strategies that are being developed or have been tried. So the chemical ablation of neuroendocrine tumors, really alcohol ablation, has been used and is a potentially effective method. It really just involves a volume calculation and injecting alcohol into the lesions, into the solid lesions. And the main issue here is that these procedures generally carry a 10 to 20% risk of pancreatitis in most case series. So the alternative to this is the non-chemical ablation strategies. And I listed these 3 here in particular because these are the 3 approaches that are to some extent closest to having endoscopic applications being available. But to this day, all our data is with radiofrequency ablation, which causes a coagulative necrosis, a thermal-based coagulative necrosis in the tumor. This, just as a sort of a quick aside, not as an advertisement, but this the infrastructure that you need for these ablation methods requires a generator and an EUS guided needle. That's a specific needle. That's true for all of these emerging and currently available technologies. Most of the data I will present, or all of the data I will present actually, is using a 19-gauge EUS RFA catheter with an internal cooling system, which has an important role in increasing the efficacy of this strategy. So how do we consider who is a good candidate anatomically and otherwise for EUS RFA? So the proximity of the lesion to the pancreatic duct and to the various vessels is very important. I will get back to contrast enhanced EUS to select treatment area. And then cystic versus non-cystic tumors are important. Cystic tumors may carry a slightly higher risk of complications. And then your ablation zone is somewhere between a 5 to 10 millimeter radius or 5 to 14 millimeter radius that one needle puncture can ablate with the different available catheters. This is always a moment of truth. Okay, this is going to work. So here under the processor, you see this little dark area. For those of you who are not endoscopists or EUS costumed, that round thing is the 2 centimeter or 1.5 centimeter neuroendocrine tumor, and the needle is already in it with this white fuzz. Can't talk quite as fast as the video, but this white fuzz kind of filling the lesion, and you can now see that this white effect is the sort of post-ablation effect. One of the things that I have found very useful is to combine this treatment with contrast injection. So on the left, you can see the tumor now lighting up kind of in bright orange. In the middle, before the ablation, then we deliver the ablation, and it's a little easier to appreciate on the still images, but post-ablation, you essentially lose the contrast enhancement in the tumor, and it kind of helps you confirm whether you have succeeded to ablate the majority of the lesion. So how do we do with this treatment for non-functioning neuroendocrine tumors? This is a study that we have just completed with several centers around the country, or maybe around the world a little bit, of about 48 patients. The majority of them were grade 1 neuroendocrine tumors in the pancreas, and the average size of these were about 13 millimeters. So there were some tiny ones in there. Those are mostly based on patient preference or request, but the average size was around 13 millimeters for these lesions. And this is our response rate. So about 60% of patients achieved at final follow-up, and this is of course a retrospective study, so the follow-up intervals vary a little bit, but 60% of the neuroendocrine tumors completely resolved. About another 30% had partial response, so a 30 to 90% reduction, and about 9% of them had no response despite ablation. This is an important slide for two reasons for me. This sort of outlines how the tumors respond at sort of their initial follow-up when you first look at it after ablation 10 to 15 weeks later, and how the response evolves. And I think this is an important concept in this. When you ablate these tumors, it's interesting that many, many months later, you see sort of continued resolution of the tumors. And then, of course, multiple additional treatments can increase the response rate. We saw very few side effects in these 46 patients. Essentially, one grade 3 side effect was seen, which was abdominal pain, bleeding, requiring hospitalization, but no transfusion, and no pancreatitis, or 2 cases of mild pancreatitis were seen. One of the things we looked, and this is important, the procedure is not standardized. How many ablations we do, how frequently we go back, et cetera, are really not standardized yet. But we have learned that at least doing 3 ablations in each tumor increased the likelihood of response in our multivariate analysis. On the flip side of this is a nice study that we also participated in. A number of centers, some here also participated in looking at the efficacy of this treatment for insulinomas. Again, one of the areas of intermediate risk lesions, which are potentially good candidates for RFA. And this was a propensity analysis, propensity score matched analysis. And what we showed is that with actually reasonably high efficacy and very, very minimal adverse event rates, we were able to achieve durable response in insulinomas with ablation compared to surgery. It's notable that there is a subset of patients that just don't respond, or their hypoglycemia symptoms don't resolve after the initial ablation, and you kind of get that relatively early after treatment. When you treat these patients, and I've done a handful of insulinoma patients, it is one of the most rewarding things, because sometimes patients come in symptomatically hypoglycemic, and within a day or two, this resolves after the procedure. But there is about a 10–15% of patients who don't respond. Not sure we understand why, but those who did have durable responses after ablation. So this is kind of the summary of the currently published series, which again, a complete response rate in neuroendocrine tumors of somewhere between 55 and 100%, and a no response seen between 0 and 18%. So reasonably high efficacy. The other thing to note is that in all of these studies, there's about a somewhere between 10 and 20% grade 1 and grade 2 toxicity, and very low rates of pancreatitis seen with the treatment. So this is my sort of humble attempt of how I approach neuroendocrine tumors now, or at least how I discuss them, and where I kind of insert ablation in the discussion. So for functioning neuroendocrine tumors, really for insulinomas only, I discuss ablation, and predominantly in those that have a less than 2 centimeter lesion. For non-functioning tumors, I think, again, between 1 and 2 centimeters, to some extent, depending on the grade. Grade 3, 1.5 centimeter tumors are quite rare, but for the majority of 1 and 2 centimeter tumors, at least it's worth a discussion. This slide is certainly not to say that this is the recommended treatment, but I think there's a rationale to at least discuss this as a potential treatment for neuroendocrine tumors. And I think this is my last slide. So just to, again, reiterate that I think we will be seeing a lot more of these localized neuroendocrine tumors. The majority of them are small, but I think even these small tumors, and I think we need a little bit more natural history data, I think we will learn that they carry a significant risk, and there is an opportunity to sort of intercept that, that pathway to potentially larger and more aggressive tumors. Of the US guided therapies, I think RFA has the advantage of being about equally, if not more effective than ethanol ablation, with probably a lower risk of pancreatitis, although certainly no head-to-head studies. And I think the ideal patients for this are the kind of intermediate size neuroendocrine tumors, with a lot of work to be done on standardizing this technique and figuring out the appropriate surveillance of these patients. Thank you very much for your attention.
Thank you, Dr. Gonda. Our next speaker is going to be Dr. Matthew Moyer, a professor at Penn State Health, and he concentrates in both the clinical and research applications of interventional endoscopy, gastrointestinal cancer, and precancerous states. You may know him from the CHARM-2.
Thanks, Sarah. Yeah, good afternoon, everybody. I just want to thank the organizers, Randy, Melina, and everybody who was involved for inviting me to speak today, and Pradeep and Sarah for taking the time to moderate. Appreciate it. So I'm here to tell you and talk to you today about a very exciting minimally invasive treatment option for mucinous type pancreatic cysts. And I was just telling Thomas and Adam Slifka last night that soon, and I hope very soon, I'll be giving this talk in a session that doesn't have the term controversies associated with it. But here's hoping. Well, we got a switcher now. That's great. Okay, no, this is well known to this group, but obviously pancreatic cancer is well known to us as having a dismal prognosis, and it's only growing. And I'm here to make this argument that we can pattern an effective minimally invasive treatment option here after the success we've had at colonoscopy, polypectomy, and dropping the rates of colorectal cancer. What that requires is a precursor lesion that has a long dwell time and gives us an opportunity to intercept it during that course time. And I'm here to tell you that for a portion of patients, that is true. So we're talking about the mucinous pancreatic cysts. As you know, pancreatic cysts are very common, about 2% of the entire population. In fact, Michael Wallace's group just published a study last year that suggests that the prevalence is much higher than that, probably about 10% in a young, handsome group like I'm looking at here, and much higher in our older population. The vast majority of these are going to be mucinous. When we say mucinous, we mean precancerous. That has a very particular chemical profile. If you would sample that cyst, it has a well-known chemical profile, a well-known molecular profile that some very smart minds here at UPMC have helped pioneer, and a very helpful cytology profile, although it does have low sensitivity. So those that do colonoscopy and polypectomy kind of recognize this sequence here. And that on the left is a very low risk pancreatic cyst, mucinous type pancreatic cyst. It has no high risk features. That was a young school teacher in our local community. But if you give this time, if you see the histology on the bottom, these mucinous columnar cells will start becoming, or a portion of them will start becoming more and more dysplastic. You can see, does this pointer work? I'm not sure. Well, at the very bottom, you'll see that those cells are starting to pile on top of each other. They've lost contact inhibition. They're causing and forming a mural nodule until finally, after a period of years, you'll see what you see on the right, which is frank adenocarcinoma. I think what most people don't understand, and I would like to explain here, is there are two real pathways to pancreatic adenocarcinoma. There is the ductal pan-end lesion that we're very familiar with. This is a microscopic event that happens at the very periphery of the pancreatic ducts. And then, as this research and basic science article in Gastro a couple of years ago has pointed out, you have the macrocystic event of the mucinous cystic pathway. This is a large macrocystic event. It happens in the central pathways, and it happens sort of in an orderly, progressive way, getting larger and larger until it frankly degenerates. And even if those patients develop cancer, you can see on the bottom right that the outcomes of operating in those cancers are different. They're better. This is in some, it's controversial, but we feel like those are two different pathways. So this is not a talk about surveillance. I'm just going to hit this real quick, and we'll get to what we're talking about in 15 minutes. But surveillance is by far, if I could tell you one thing about managing pancreatic cysts, it's pick a guideline, the Kyoto guidelines or the ACG guidelines, and know them. That fixes 90% of the problem in pancreatic cysts. So surveillance is how we take care of them. They come back for an MRI. We look for degeneration, for the development of high-risk features, and it'll tell you exactly when and where you need to bring these patients back. But that's totally non-therapeutic. It's expensive, and it causes a lot of anxiety to patients. Obviously, if you have one that has multiple high-risk features or stigmata of malignancy, surgery is the gold standard. It obviously is effective, but we need to keep in mind that even in high-volume centers, it has a significant morbidity and mortality. So for patients between those two groups, low risk cysts, they're just best for surveillance, and very much with stigmata malignancy, best for surgery. That would be great if we had a minimally invasive treatment option we could offer those patients. So can we replace surgery with its restrictive strategy, its morbidity, its mortality, and expense with a less invasive treatment option in appropriately selected patients? Well, here I'm obviously here to tell you we can. Now, the middle slide, you'll appreciate this, Sarah. I used to have a picture of an open Whipple, which was much more dramatic and made my argument a little bit better. But my partner, my surgical partner, forced me to put in the new robot, so it's a little less exciting. But so this is how it works. The needle goes into the pancreatic cyst. We essentially draw all the fluid out, and then you replace it with whatever you're going to treat that cyst. Originally, this was done by Bill Brugge's group by lavaging alcohol in and out of that cyst. And this is the trials that were done up until the time that I got involved. Now, I'm just going to focus on the prospective trials. If you're interested in this space, I would caution you to stay away from the retrospective stuff in this area, because it's replete with all kinds of third confounding variables and biases. But here's the prospective work, and you can see if you look at the complete response, alcohol alone has a fairly dismal complete response rate, but it does work. But down in the bottom, I'd like to point that out to you, but I don't have a pointer, I don't think. Oh, there it is. Here in this group here, you can see that the South Koreans came up with this great idea of doing the alcohol lavage, pulling that out, and then replacing it with a chemotherapeutic agent, paclitaxel. And you can see those rates went up to 50 to 79%. That's real efficacy. The problem is this: anytime alcohol is used in the ablation protocol, you have serious adverse event rates, not just abdominal pains, serious adverse events of somewhere between 4 and 10%. So that really limits more widespread adoption. So that led to our CHARM trial, which is a randomized prospective study that asked two questions. One, is alcohol even required for effective pancreatic cyst ablation? And number two, if we replace alcohol with a very specific chemotherapeutic admixture that's specifically designed for pancreatic neoplasia, can we replace it from the ablation process? So we enrolled patients who had mucinous cysts from 1.5 to 5 centimeters. And there were other inclusion and exclusion criteria, but we don't really have time for that. And the primary outcomes were the percentage of patients who got a complete response at 12 months. How do you determine that? You measure volume. I'll show you how you do that. And then rates of serious and minor adverse events within 30 days of the procedure. What you'll see here, if I can call your attention to the alcohol lavage arm, you can see that they ablated at a rate of 61%. In the entire alcohol-free arm, they ablated at a rate of 67%. So alcohol is non-inferior, or alcohol-free is non-inferior to alcohol. It's not required for ablation. But the more exciting part is this: serious and minor adverse events were all localized in the alcohol arm as predicted. There were no complications in the alcohol-free arm, suggesting that when you take alcohol out of the process, adverse event rates fall dramatically. This is how you measure response. The original cyst is measured on an MRI. This is a local professor, retired, who came in and had the procedure. You can see that the cyst is right here. It's just under 3 centimeters. You measure the radius in 2 dimensions, take that average, plug it into the equation, 4/3 pi r cubed. Remember that volume calculation from high school? You can use it again now. And you measure the volume. And then what you do is you take a MRI 1 year after the ablation, right here, and you remeasure the volume. If you got 95% or greater reduction, that's a complete response. And you can see that this cyst is no longer identifiable. So that's obviously complete response. That's how all patients are measured. Here is our results. You can see that at 6 months, you got a pretty exuberant response for most cysts, but I want to call your attention to 2 things. One, right here, some patients require a full year to express that ablation. This happens in a very progressive, slow way. You infuse that chemotherapy, it gets into every nook and cranny in that tumor, and it kills the tumor over months. It's not a fast, traumatic, upfront process. And also, I want to acknowledge that there are such things as non-responders. There are some patients who don't respond right now. And just like Nick Shaheen, when he published the RFA with Barrett's esophagus, or lots of other ablative strategies you can think of, it's not 100% effective. And so we're going to figure out how we can raise that number. Now, this is a super important slide, because when I gave this original trial presentation at DDW, there was lots of pushback and lots of criticism, and they generally ran across the kind of 3 things. 1, how do you know you got rid of it all? 2, how do you know it won't come back? How do you know that clinical response is the same thing as your radiographic response? Well, those are all 3 ways about saying, what's your long-term follow-up? And here it is. So we followed these patients over 3 years. And you can see that 87% of patients who got complete response maintained that long-term for at least 3 years. No patient who was treated went on to get high-grade pathology or any kind of adverse event based on neoplasia. And interestingly, 4 patients who were non-responders or partial continued to progress to the next better case by 3 years. So it's a very delayed treatment response to some of these. This is an evolving process. I can't explain that, but it's positive news. All right, let's see how this works. Can you click that video for me, please? Or can I do that from up here? There you go. Thank you. So this is generally how the process works if you haven't seen it. Essentially, you find that mucinous cyst, you'll draw all the fluid out after you found a nice stable position by EUS. You'll measure how much you removed. You'll put the exact same amount of chemotherapeutic agent back into the cyst. You'll reconstitute it essentially to its original size and dimension. There's no reason to overfill it. Here's what it looks like in real time. That's a pretty big cystic tumor. I've just put a 19 gauge needle in it. I'm going to drain it dry because it's nice and stable. And when the chemo comes back in, it has this snow globe effect showing you where it is and where it's not. You can see that this big complicated cystic tumor sitting on top of the IVC is all anechoic. But when you draw that fluid out and you replace it with the chemo, wherever the chemo is, it's all snow globe. Wherever it's not, remains black, anechoic. So you know what you have to treat and what remains to be treated. That's a completely treated cyst. This procedure took 22 minutes. The patient came back in 3 months for a second treatment. So it is a minimally invasive treatment option for appropriately selected patients. Here's a 55-year-old gentleman who went through one of the trials. He has a 3.3 centimeter cyst. You can see it in the MRI here on top and the MRCP on the bottom. Those are two different views. I usually include the MRCP so people don't think I'm trying to cheat by using different cuts, because those are generally 3D models. And here you can see his follow-up at 12 months. You can see that there's a little scar left in the neck where that cyst had been 1 year after alcohol-free chemoablation. The MRCP correlate is down here. You can see a little scar left. That's complete ablation if you measure it out. Here is one of my all-time favorite patients. She's a retired lawmaker from Harrisburg. She had a 3.5 centimeter cyst. That's a big cystic tumor. You can even see it's pressing and causing mass effect against the CBD, right? So you're looking at the MRI on top, MRCP on the bottom, and here's her follow-up at 3 years. You'll see that there's no cystic tumor left. I challenge you to find that. You can't. So that's complete ablation. Now, I do a lot of EMR, ESD, and as a group, we're like often criticized by what's called conference bias, showing your most pretty cases. And so my fellow said, well, you shouldn't let that fall for you now either. So here's that 30% that have partial responders. Here's what that looks like. So here's a 76-year-old female. This is real time, kind of honest reporting here. 76-year-old female, multiple comorbidities. She has a 4x2 centimeter cystic tumor. You'll see that it has what looks like a few septations in it. And there's her MRCP in the bottom. And then when she comes back in a year, you'll see that it's much smaller. It's now 1.4 centimeters by 1 centimeter, but it's not gone. If you measured that, that's less than 95% reduction. That's a partial response. Now, we've showed in our long-term follow-up that will be durable as well, but that is what a partial response. Not all of these cysts just vanish, especially if there's multiple septations. Okay. So what cysts are most appropriate for EUS guided chemoablation? Well, again, I said this before, but it's worth repeating. Most cysts are small. They're less than 2 centimeters, and they're best followed by routine surveillance per whatever guideline you follow. I would suggest ACG or Kyoto. Mucinous cysts with multiple high-risk features or stigmata of malignancy, they need to be evaluated by a multidisciplinary committee at your high-volume center and surgery considered if appropriate. However, for patients in the middle ground and amendable to ablation, alcohol-free chemoablation offers a minimally invasive treatment option with a 67% rate of complete ablation and very low adverse events. And there is an international position statement that I was part of, along with John DeWitt and Bill Brugge, that you can reference at the end of this talk. Okay, here are the indications and contraindications. I'm looking for the timer. Where am I seeing that? Oh, geez. Okay, well, this is technical and I'll just let it go. But I do want to say that the Koreans have also put out 2 long-term follow-ups. The Choi group followed 164 patients. These were prospectively accrued, and they showed that 72% got complete ablation, 98% of those patients maintained it. And here is a 1-to-1 propensity score comparing surgery and US guided chemoablation. Not surprising, surgery wins as far as complete ablation, and US wins as far as safety and patient scores. One thing that's interesting is they followed them out to 10 years and showed a 33% of delayed complications in the surgical group, which they claimed was localized all to diabetes. All right, so here's our longest term follow-up. That shows the same thing as before, but I just want to point out that we have been able to come up with what's called the CHARM radiology reduction protocol. In other words, we reduce the amount of radiology that's required after complete ablation. It's safe. We showed no recurrence, and it actually ends up saving thousands and thousands of dollars to the patient and subsequently the medical establishment when we're not getting MRIs every 6 months for a higher risk cyst. And what do patients think about this? Well, it turns out patients love that idea. I bet you didn't know this, or maybe you did, but patients don't like the MRI. Some of them abhor it. They're claustrophobic. Some of them don't like the idea of surveillance at all. They'll tell you that they start wondering if they have cancer weeks before they come in for the image, and they wonder if this is the time you're going to tell them. Almost no financial burden, interestingly, but if you give them a chance at reducing that radiology, they'll jump on it, or at least a portion of it. In blue, you'll see there's some patients that are just married to this whole idea, and you can't talk them out of it. All right, so they should be evaluated in a clinic. This is a multidisciplinary environment procedure. It's an academic tertiary care hospital environment, and it's something that Thomas can do because he's an interventional endoscopist as part of a multidisciplinary program at NYU. And in fact, Thomas is doing this, right? And I'm calling you out, Thomas, a little bit, but you're doing this. I know you are. And Jorge, if he's still here, I know he's doing it too. So it's not just me in the wilderness anymore. Recognizing and managing adverse events. Almost all of these, a fair amount of patients, up to 30% are going to get abdominal pain and nausea that'll clear within 3 days. Serious complications are unlikely, but you can get pancreatitis. And these are the centers that have gone through our onboarding process, which include Thomas, as I said, but also Cheyenne Tucker, West Virginia, Vanessa Shammy, we just onboarded San Francisco, lots of other centers, and this is rapidly gaining a wider adoption here, I guess is the point. But it needs to be done in a careful way. It's a program. It needs to be part of a specialized team because the nurses have to be involved in this too. And we have an ASG video that'll walk you through how to do this, and I'd be glad to talk to you further if you're interested at your center. Finally, I'll leave you with these further reading points here, and I'm sorry for running over. Okay, thank you very much.
Thank you so much. Our next speaker is going to be Dr. Nirav Vasani. He is an associate professor at McGovern Medical School at UT Health in Houston. His talk is Radiofrequency Ablation of Pancreatic Cancer, A New Hope. Anyone that has a Star Wars reference in their talk title, I appreciate.
Hi, everyone. So today I'm going to talk about the most controversial topic. So this is a radiofrequency ablation in pancreas cancer. These are my disclosures. We know there are several treatment options which are standard of care when we talk about pancreas cancer. I strongly believe that in the next 4 or 5 years, US guided ablation therapy will become one of the treatment option for pancreas cancer. My objective today is to introduce you to the term called endoscopic immuno-oncology, where you can use local ablation along with systemic chemo to change tumor microenvironment. And if you do have immune activation post-ablation, not only you can see the local effect because of immune activation, but you can see the impact at metastatic site also. So you can ablate pancreas cancer and you can see reduction in a liver metastasis or lymph node metastasis. So that's the abscopal effect. And then I'll go over some of the data from our ongoing work in a pancreas cancer ablation trial. So my journey in this field started about 8 years ago, where we initially did a phase 2 safety trial between 2016 and 18, and we enrolled 10 patients with unresectable pancreas cancer. And we found this procedure was very safe, and you can very easily incorporate along with any ongoing chemotherapy protocol. When we looked at the long-term data, we saw survival benefit in these 10 patients who had undergone this trial, and overall survival was reaching close to 19 months. Moreover, 2 patients had a totally out-of-box response. This was one of the patient who had an unresectable disease with involvement of portal vein as well as celiac artery. And after 2 ablation, patient did become resectable, and this underwent a successful R0 resection and had a 4-year tumor-free survival. There was another patient who had a 2 centimeter pancreatic head mass involving ampulla and 6 centimeter mediastinal metastasis. And this patient had progression of disease on first line chemo. And at that point, under the trial, we offered RFA of primary lesion and metastatic site. And this patient, after again 3 ablation, had a complete radiological response at both sites. We continued this patient on chemo for another 6 years. And at that point, we did offer a Whipple, and he had again R0 resection at 9 years. At original disease was metastatic. He's still alive and doing well. Now, these are very anecdotal examples, but this raise question that why in some patients with pancreas cancer, we saw impact of local ablation. And this changed trajectory of my career. So our hypothesis was that when you do EUS guided ablation, that does cause coagulative necrosis, and that releases the neoantigens and particles, which then can activate body's adaptive immune system, and that likely is responsible for reduction in primary tumor size and abscopal effect on distant metastasis. So to prove this hypothesis, we selected a syngeneic mice model with a KPC cell line where we inject the tumor cells in the both flanks of the mice, and then we do ablation at one site, and we look at the impact of ablation at the site you treated with ablation. So that would be like your primary tumor, and the same mice, the site you did not treat with ablation, so that would be non-RFA treated site or like a metastatic site. What we notice is that with RFA, not only you see coagulative necrosis at your RFA treated site, but you also see equal degree of coagulative necrosis on a non-RFA treated site. And at both sites, we saw marked reduction in a tumor growth rate after RFA. When you further dive down in a tumor microenvironment, so what we notice is that there was the fibrotic stroma of the tumor was converted by collagen, and there was extensive trichome strain at both RFA treated site and non-RFA treated site. And we also saw evidence of neovascularization in both sites. Subsequently, we also noticed that there was a much higher infiltration of CD4 positive and CD8 positive T lymphocytes in distant tumor. And when we did a repeated experiments that do you do one ablation or you do multiple ablation, repeated ablation or multiple ablation was much more effective in remodeling the tumor microenvironment. We also noticed expression of PDL1 post RFA. So this tumor do not express PDL1 before RFA, but post RFA there was PDL1 expression. So that now gives you target that you can combine immune checkpoint blockade therapy. And in our mice model, we combine RFA with PDL1 blocker, and we again noticed sustained inhibition of tumor growth at both primary and abscopal site. So based on this data, subsequently in last 5 years, we started few trials at our center. So we have a pan-cardinal trial, which is NIH funded trial, where we are currently enrolling resectable pancreas cancer patients under very strict protocol. And also I have a EUS RFA prospective registry, which is more compassionate use of EUS RFA, where patients with any stage of disease who do not meet the inclusion criteria of NIH trial, we've been offering RFA. So to date, I have 37 patients in pan-cardinal trial, and we have enrolled 100 patients in our prospective registry with a combined experience of close to 610 EUS RFA procedures in Pan-cardinal trial, most patients get repeated RFA after second week, fourth week, and a fourth and sixth cycle of chemo. So roughly every 1 month, patient is getting RFA at least 3 times. What we are looking for is overall survival, progression-free survival, what is R0 resection rate, tumor-free survival, and radiological response rate. Our goal in pan-cardinal trial is 60 patients, so we are about halfway in. But prospective registry, we did finish enrollment, and I'll go over some of the data. I at least have a last patient enrollment more than 6 months ago. So we have at least 6 months data on all patients. So we had 38 metastatic patient, 24 locally advanced patient, 9 borderline resectable, and 10 resectable patient. 40 patient had less than 3 RFA, and 41 patient had more than 3 RFA. In this group, we also have 10 patients where we combine RFA with immunotherapy also. So I'll go through all this data. So when in our prospective registry, you take resectable patient, currently our median survival rate is 68 months, 12-month survival rate close to 80%, and 24-month survival rate is close to 80%, which is much higher than what you would normally expect from SEER database or even our institutional cohort of our previous patients. In borderline resectable group, we do not have enough follow-up to report median survival, but 12-month survival was 86%, 24 survival 50%. Locally advanced on unresectable disease, current median survival is close to 21 months, 12-month survival rate 71%, 24 months 38%. And in metastatic arm, median survival is about 18 months. And when we further divided these metastatic patients in those who had less than 3 RFA versus those we did more than 3 RFA. So I had 20 patients who received 3 or more RFA. For them, survival is currently approaching 24 months, again, which is much higher than what you would expect to see. So we strongly believe that combining USRF, and this is all prospective data that we've been seeing and collecting. So when you combine, along with systemic chemotherapy, when you combine ablation, we have some survival benefit. For most patients, we see good tumor marker response, and as in this patient, usually after each RFA, tumor marker continues to drop by several folds. And usually by third RFA, tumor marker number starts to become close to normal. We also see about 70 to 80% good radiological response rate. This is one of the patient where we just did a pancreas ablation, but liver metastasis site also significantly reduced, kind of highlighting abscopal effect here. This is a patient data. So we have about 26 patients who underwent post RFA Whipple surgery. And so very similar to what we see in mice model, in a human patient sample, we are seeing extensive collagen in a site of a pancreatic tumor with a very few foci of tumor cells left post ablation. And our surgeons currently putting their trial where they compared this 26 patients to their previous 26 patients, and we have not noticed that RFA negatively impacted surgical outcome in any of these patients. In fact, they were able to offer more robotic surgery post RFA compared to without RFA, mainly due to reduction in size. Looking at complications, post procedure abdominal pain, nausea, vomiting is common in about 30% of patients, but that's usually very self-limiting. It stops within 2 hours. So most patients you can discharge from your procedure suite. We had out of 610 procedures, about 7 grade 3 adverse events, and that was mainly GI bleeding requiring blood transfusion or repeat endoscopy in 3 cases. 1 case of duodenal perforation where I did RFA through the metal stent, and RFA energy conducted through metal stent at ampulla that led to perforation. And biliary stricture if you are working very close to bile duct and you don't have a stent in place. Most of this adverse event happen in my first 250 patient experience. That led to some changes in protocol, and lately we haven't noticed any cases of GI bleed or perforation or stricture. So in conclusion, I think for locally advanced or metastatic patients, rather than just continuing chemotherapy. RFA is a safe and effective, and most therapeutic endoscopists can do this procedure very safely. For resectable and borderline resectable, probably better done under clinical trial. Any patient who is high-risk surgical candidate or post-surgical recurrence, this is a good option. First picture is my first patient in our pan-cardinal trial. He has finished his 5 year since his Whipple surgery. And the second patient is the patient where I showed you abscopal effect. So he was one of our first patient in pan-cardinal 2 trial, where we are offering RFA, chemo, RFA, and immunotherapy with Keytruda. And he's also 2 years since we started him on the protocol. I just want to acknowledge my research team and funding sources. Thank you very much for this invitation.
Thank you so much for keeping the time and saving some time for the discussion. And I want to invite all the speakers to come to the podium, please. I really want to thank the speakers for the work they're doing in this field and for excellent talks that they just provided. And I open this session for questions.
Great presentation, Dr. Moyer. My first question is, have you compared EUS RFA for pancreas cyst versus chemoablation for pancreas cyst? And then my second question would be, how do you do surveillance after chemoablation? Is it the same surveillance as a regular pancreas cyst, or do you have a different surveillance protocol, and what would you look for?
It's a great question, but can you repeat the first one? I didn't hear.
How would you compare? Have you performed EUS guided radiofrequency ablation for pancreas cyst? I mean, there were some exciting talks from DDW with ERASE trial, which had looked at EUS radiofrequency ablation for high risk.
Right. Well, let me answer the second question first, which is, okay, you've ablated a patient. Now what do you do with the radiology? So oftentimes these are higher risk cysts. If you've seen the guidelines, a lot of those patients are coming back quite frequently. One of the guidelines is even alternating MRI and EUS at 3 to 6 months. That's a lot. And we have a radiology reduction program called the Charm Reduction Program, where essentially all patients who undergo treatment come back for their first MRI at 1 year. It seems like a long time if you're a little bit nervous about the cyst, but really we need that length of time to see the response. If you're worried about it oncologically, you'll bring the patient back for a second ablation at 3 months, but the imaging is always 1 year. Then the next year, and then if the patient has a nice response, it's stable, we'll actually offer that patient to go out to every 2 years after 2 annual images show stability. That's a significant reduction in the amount of radiology that's used, patients like that, and we have not shown an oncologic risk to that. So that's one of the reasons behind this, that one of the advantages of doing this. The second question is, what about RFA? RFA, as you've heard from my 2 esteemed colleagues here, has a real role in solid lesions. Does it work in cystic lesions? Well, the French did a prospective study where they showed about 64% complete ablation. Now, they didn't put down how they defined that, but they did have a 6% rate of serious adverse events and some that required surgery. I think the idea of generating heat, which has to go up to 50 degrees centigrade in a cyst to destroy it, is that traumatic ablation versus atraumatic ablation I was referring to earlier. So the amount of data behind this, prospective data behind RFA for pancreatic cysts, is not there. I think the risks is much higher. And I think that may be why Boston and Irby pulled their devices. It's really just the one left, and hopefully it sticks around for these guys' work. But I hope that answers your question.
I'm back. So just a curious question for like in the perspective of patients in general. Would ablation recommended to patients with certain mutations for pancreatic cancer, like knowing that there could be a risk of it coming back?
Yeah. So we do not recommend ablation as the only therapy. Ablation is more like a added on therapy to ongoing systemic chemo till we learn more. We do have a lot of samples and data on patients and their tumors and genetics. So once we go through all the data, we may get a little bit better idea that which patient responds very well to ablation versus which patient did not. I can tell you of the 26 Whipple samples we have, we at least had 3 patients had a complete pathological response. So the entire tumor had no cancer when we take it out, and a lot of the patients had a near complete response. So we know that certain patients ablation will work much better versus other, but I do not have clarity that which tumor genetics affects that.
Okay, well, I'm aware of like some of the genes like BRCA is like one of the ones that could make you predisposed for pancreatic cancer.
Right. We have patients with a BRCA mutation and BRAF mutation and other things in our cohort. So probably, hopefully by next year, I can have a little bit more data and genetic markers and which ablation strategy will work best.
Thank you.
Hi, Michelle Lewis from Mayo Clinic. I have a question for Dr. Moore. So your guidelines recommend this treatment for 2-centimeter mucinous cysts. The latest publications say by age 80, 40% of the general population will have cysts in their pancreas. So this is a very vulnerable population. If you tell someone who's not in the medical field that they have a tumor or a neoplasm in their pancreas, they're not necessarily certain what a solid tumor and a cyst is. Everyone knows somebody from their neighborhood or their church who had pancreas cancer. They're very vulnerable, very likely to go along with whatever we as professionals recommend. So that really concerns me that we're talking about doing an invasive procedure on a cyst that's so common in the general population, and MRIs have no radiation. We all have patients who have developed solid tumors elsewhere in the pancreas that we pick up on surveillance MRIs that aren't related to the cyst. So it's fertile field. So are we really at a point where we're going to be aggressive as to treat all these 2-centimeter mucinous cysts?
Yeah, it's a great question. Let me reassure you a little bit. So to answer your question, let's just say in the 80 group, the 80-year-olds, that's a 37% prevalence. Across the entire prevalence, something like 85% of pancreatic cysts are less than 2 centimeters. And so I hope I made that point, that patient selection is very important. Most cysts are small and best managed by routine surveillance per accepted protocol, be it either whatever guideline you believe in. We follow the ACG one. That's the vast majority of patients. And then if you run across the spectrum and you find those with stigmata, malignancy, or multiple high-risk features, that really needs to be seen by a multidisciplinary committee and surgery considered if appropriate. It's the middle ground, which isn't a huge population. And to answer your question that most patients don't quite understand it, I completely agree. That's why most centers your size, our size, and I would suggest most big centers have a pancreatic cyst clinic, because it's our experience that most doctors don't understand this real well. And that's why you need a specialized group to really educate providers, educate patients, and follow the guidelines typically. So we're not proposing that you treat your 1.8 centimeter cyst. This is for your 2.5 centimeter cyst that's growing, that's appropriate, and has higher oncologic risk. Now, there's older surgical data that shows the risk starts at 2 centimeters, and a traditional risk would be 3 centimeters. But going back, that's where the risk starts. That's where technically you can ablate a cyst, but nobody's proposing ablating a cyst that's smaller than that. That would be the smallest one you would treat.
But the first statement in your guidelines say 2 to 6 centimeters. So 2-centimeter cyst, no solid component, no mural nodule, no main duct involvement. You're going to do something invasive.
Correct. 30 minutes, almost no risk. Just ask the patient if they want that.
But that's my point. I mean, I think if you suggest that, that's what's going to happen. And that's a huge population. And I don't know.
I
that
don't
they-
think it is actually. Now,
Expect this to
it,
1 to 3 millimeters a year. There are lots of patients who get to be 2 centimeters.
I suppose I suppose you're right. But if you use a baseline at 2 centimeters, that's where the oncologic risk will start. And remember, most cysts are less than 2 centimeters. That's a vast majority of cysts, and they're low risk.
I think we have time for one more question. And a comment.
So, and I think that excellent job, all three of you. I think that one of the central themes for all three of you is that patient selection is extremely important. You have to identify the right patients. And I'll be honest with you, taking a patient like patient A, patient B, based on imaging, based on if they just have pancreatic cancer, is a poor way of doing it because we know everything is very heterogeneous. Cysts are extremely heterogeneous. Matt, you mentioned about KRAS and GNAS. Some cysts have KRAS, some have GNAS, some have BRAF, some have NTRK, some have ALK. It's not that simple as just a KRAS and GNAS. The same goes with neuroendocrine tumors. It could be MEN1 altered ATRX, DAX, BEN2. It could be an alpha cell. It could be a beta cell. Every one of those neuroendocrine tumors is very different in how they will transform or even leave the pancreas. How are you guys dealing with this? Because it doesn't seem clear to me if you are truly selecting out patients other than based on a general gestalt that it's a cyst, it's a neuroendocrine tumor, size, but we all know that that's an indirect measurement, doesn't tell you underlying biology. And even the setting of pancreatic cancer, someone had mentioned, 10% will have an HRD alteration, the 2% will have a mismatch repair deficiency, and then ever so frequently, you'll have like really that FGFR2 fusion gene, which I would never touch with an ablation. I would give them chemo. That's the three questions there.
Okay, that is a tough question to close the session with, but thank you. I think, at this point, I think this is very early days still for patient selection and even for this method. But I kind of think about it in a way that, if these interventions really hold up to be as safe as the initial data suggests and the adverse event rates are as low as they are, I kind of equate it with colonoscopy polypectomy or Barrett's and ablation. And I think we have to understand who are our patients, what is their risk. We have to understand how we will risk stratify them. But we don't do that when we do a polypectomy because we know that the polypectomy is a safe procedure and you don't really need to know the biology of that polyp before you cut it out. Now, I'm not suggesting it's totally equal, and I'm certainly not suggesting that we have enough data to support that this is safe enough as a standard polypectomy is. But I think that we're, at least in the world of neuroendocrine tumors or in cysts, I'm not sure that we're going to have a breakthrough ability to classify these incidental lesions in the near future. Maybe Atur, you will provide us in the next couple of years, but at least in the very near future, a breakthrough ability to really further risk stratify them beyond the assessments that we have. So my focus, I will end this sentence once, my focus is to actually show that this is a reasonably safe procedure to offer to most patients who are medically, fit and appropriate for potentially a preventative procedure, and for whom I hopefully will not harm.
Okay.
I'll just jump on. Kind of agree with that. I think your level of certainty goes up in accordance to the seriousness of what you're offering, and the safer and more straightforward it is, I think that the less your pretest probability has to be a gold standard of some sort. Just like the example that was just given of colonoscopy polypectomy. You're not going to biopsy that, make sure it's an adenoma, and then come back. not when you have a relatively safe procedure. And I think this is the same. But it needs to be admitted that in 2025, there's still a little uncertainty in making the diagnosis of a mucinous cyst, even when you put it all together. And I always say it's an entire consortium diagnosis. Is this mucinous or not? You would never hang your entire diagnosis on a CEA level. Put everything together, the clinical picture, the cytology, the CEA, the glucose, was it viscous, all that kind of stuff. And Ator, I hope you give us a better understanding of where these risk factors will come from in the future, and that may help risk stratify which patients need to be treated in the future or not. But right now, I don't think we're there. I think the biggest prospective trial that just came out last year was out of the University of Ohio, and Sean published all of his next generation sequencing with all of his pathologic data, all his surgical data. And his specificity was very high, but his sensitivity for high-grade dysplasia and adenocarcinoma was reported as 6%. So I don't want to use that as a criteria right quite yet for who we're treating and who we're not.
Okay.
Final comment?
Yes, a final comment. So as we do not know on the pediatric side and the adolescents when they present with cysts, that may not follow exactly your schematic of size or even phenotype on the imaging. And we do deal with high-risk cysts in children or even malignant lesions too. So we don't want them to be blown off. So I'm going to tell you our approach is that we use a multi-pronged approach when we are approaching cysts. And I'm hoping this will come in some of the upcoming guideline revisions. We have to incorporate age because that's a whole life of radiation and what's going to follow, or EUS and MRI alternating, but also the NGS data that we get on top of everything, because there are some tests, as you mentioned, with really high accuracy, but the more data we put together, then hopefully we could improve our positive and negative predictive values. That's my comment.
Thank you. Yeah, I'm sure a lot of people have more questions. We can take the off podium. And I thank the speakers as well as the audience for their attention. And I think we'll end the session.